brief about the genetics basics of the cancer. In general, the cell division and maturation of the cells is controlled by the genes, and any mutation in the genes could lead to a cancer formation, and most of the genes leading to cancer or discovered genes are in the somatic cell level, 90% of them, and only 5% were at the germline level, which is inherited. And retinoblastoma, the retinoblastoma in general has two forms: hereditary, or what we call germline, or non-hereditary, sporadic, or the somatic type, which is more 60% of the time of the cases. And the hereditary, and the germline one, inherited form, some patients, they have family history, only 10%, and the majority they don't have family history, and the majority are bilateral cases, but 10 to 15% of the cases, they come with unilateral disease, also with negative family history. The somatic or the sporadic ones, they never have family history, and always they are unilateral, and they don't have any risk for second cancer. Let us talk at the cell level of the inheritance of the retinoblastoma. In somatic cases, in general, not the retinoblastoma ones. So in somatic cases, the defect, let's say in breast cancer, the defect in the breast, so this patient with defective gene in the breast cancer cannot spread the gene to the offspring or to the children, because it's not at the germline level. While the germline cancers or the inherited germline tumors, they have the gene in the sperms or in the ovary of the carrier or the patient, and they can spread the tumor to the offspring. So the hereditable type of retinoblastoma, it is autosomal dominant at the cell, at the inheritance level, but at the gene level, it's recessive, and it occurs at a younger age than sporadic form, and most of the time it's multifocal or multilateral, and they may have family history in 10% of the cases, and 5% chance to develop the 50% to develop the cancer in the offspring, or to spread the gene to the offspring, and 40%, because the penetrance is 90%, to spread it to the offspring, and they have lifelong increased risk of the second cancer, almost 5 to 6%. So the hereditary retinoblastoma, they have the gene defective at the gamete level, which is the sperm or the ovum. So if you have one defective RB gene, the child will have one defective RB gene in all his body cells, including the blood, the bones, the soft tissue. And when he have the second hit at the retina cell level, so he will have two alleles of the gene defective. So he's now ready to develop the retinoblastoma at the retina. And if he has a second hit at any other body site like bones or soft tissue, he can develop the second cancer in the bones or the soft tissue. While the somatic type, in contrary, they don't have the defective gene in the body cells. Both the gametes, the sperm and the ovum are free from the genes, and both hits happen to the child at the cell level of the retina. And all body cells are normal except the two hits that happen in the retina. So the child developed the retinoblastoma at the retina only, without risk of spreading the tumor to his offspring. So in brief, the sporadic retinoblastoma or non-hereditary type, they are always unilateral. The family history always negative for the cancer, and the presentation of the tumor, because both hits happening at the same site of the retina, so the incidence of two hits rarely come early before age of 1 year. So they come usually around at the age of 2 years, and the risk of second cancers is 0. Because as I mentioned, the all body cells are normal except the retina. While the opposite in hereditary type were bilateral or unilateral, and the family history in 10% of the cases, and I will talk about this in the next slide, and they come earlier and they have the risk of second cancer in the body. So the RB genetics by Knudsen, who discovered or described the two hits hypothesis, where he talked about the RB gene. It's a tumor suppressor gene, where if there is a defect in the gene in two alleles, the child or the patient will develop the cancer, and both copies of the gene, the tumor suppressing gene, RB1, should be defective to develop the cancer. So if a patient carry the gene at the germline level in all his body cells, he should have the second hit at the retina site to develop the cancer in his retina, and for his offspring, he can spread it to them with 90% incidence of second hit with not known causes. So this is describing the tumor suppressor gene. If you have normal gene, so we call it the brake of the car. So if there is normal gene, so the car has the brake and they cannot develop cancer. If one gene only affected, one allele of the gene affected, so still the car have the brake. But if both alleles of the gene were defective, so now the child is ready for retinoblastoma with the penetrance of almost 90%. And the secondary cancer risk in patients with germline retinoblastoma, almost 5 to 6%, as I told you, in the form of osteosarcoma and soft tissue tumor and melanomas of the skin and other organs. There is 6% of the cases what they could have mosaicism, where the defect doesn't happen in germline. In 94% of the cases, the defect has at the gamete level, where the sperm or ovum have the one affected allele. But in this special occasion, they develop the new mutation at the 4 or 100 cell level. So the defective allele is not presented in all body cells. And those cases, they could have what's called germline mosaicism retinoblastoma. So if the allele is not affected in the blood or in the germline or in the ovary or the sperm of this new product of this sperm and ovum, so if you take a blood sample, he will be negative because of the mosaicism, and the defective gene will present in some body cells, not all over the body cells, and this present in 6% of all germline retinoblastoma. This is an explanation of mosaicism. If the defected allele in the germline of the left side, he can spread it to his or her offspring, but in the right side, because the germs or the ova and ovary is not affected, so he cannot spread it to his offspring. So let's go in probability type. You are in the clinic and you are or in the ER and you receive the new patient with retinoblastoma, and you want to know, is he germline or somatic level or somatic type of retinoblastoma? So if the family history of positive, regardless of the presentation, this is 100% germline, regardless unilateral or bilateral. If the family history is completely negative and he presented with bilateral, so this is always germline. This is the area of discussion. When he come with multifocal in one eye with negative family history, it varies between the literature because it depends on who's reading the retina findings. Because some they describe one lesion as two lesions and they describe it as multifocal, and sometimes it's one tumor, but it's the growth pattern show it's like spreading two different lesions. That's why the literature is varied, but if it is clear multifocal in one eye, so this is almost 100% this is germline. The difficult cases that you cannot know is unilateral, unifocal with negative family history, up to 14 or 15%, still they could have germline mutations. And the RB gene located in chromosome 13, Q14 area, and this is large gene with broad spectrum of mutations. One of the syndromes, 13q deletion syndrome with the RB is well described, and they are features by growth retardation and intellectual retardation and dysmorphic features with hypertelorism and microphthalmia, and they present in 3 to 6% of the cases of germline retinoblastoma. So the genetic testing is very important in unilateral cases. As I told you, 15% of them, they could have germline mutation with negative family history. And the best outcome to get proper genetic testing for exclusion, if you could have a tumor tissue to send it for genetic analysis and sequencing, because missing the deletion or the mutation from the tumor is much less than missing it from the WBCs. So if you could find 2 RB mutations from the tumor and you didn't find them in the blood, so this is most likely, not 100%, most likely is somatic, but as I told you, 6% of the cases with negative blood sequencing, they still could have germline mutation because of the mosaicism. And this explains the probability you see in the textbook and in the literature about the unilateral cases with negative family history, about the risk of offspring and their other siblings of retinoblastoma. It's not 0. They can reach up to 6% because of this mosaicism and the genetic analysis difficulty in picking them. In bilateral cases, they are 100% germline mutation, but we are doing genetic testing to check where is the source of the mutation. Is it from the parents or new mutation in this child? And as I told you, 10% it is inherited from the family, but sometimes even if you test the family for the same mutation and you find it negative in the blood, still you cannot rule out the retinoblastoma in one of the parents, because he could have the mosaicism in one of his parents. And if you could see a patient with dysmorphic features, if you do microarray or karyotyping to detect large 13q deletion, will be easier for you. So there is special entity or some forms of retinoblastoma, the familiar type or the germline, they tend to be unilateral, milder form, or they could have a retinoblastoma that spontaneously regressed for no known reasons, or there is 10% of the cases they don't have incomplete penetrance. So if you have a child with a negative family history in his parents, there is 3 chances. Either one of his parents carrying the gene, but he's not having the tumor because the penetrance is not 100%, or he could have mosaicism, where he could have the gene affecting in all body cells except the retina, or he could have spontaneous regression. And if you examine one of the parents, that's why we examine the parents always in all retinoblastoma cases. So one of them could have spontaneously regressed retinoblastoma and he doesn't know. And why we do the genetic testing? Because of and differentiating the germline from somatic type retinoblastoma, it's very important, because germline retinoblastoma, they are prone to second cancers. They are prone to develop RB in the other eye if they came with unilateral cases, so early detection of the other eye and management earlier, and also to avoid radiation exposure. That's why in retinoblastoma diagnosis, it's completely changed using the CT scan to diagnose them, because exposing those kids with RB gene to a CT scan, which almost 20 or 200 times X-ray films, exposing them to too much radiation. So that's why I'm telling the resident and new graduates, never use CT scan to diagnose retinoblastoma, and never ask it for retinoblastoma cases, because you are doubling their risk many times to expose them to a second cancers, where they have cancers in the bones and soft tissue, because they have the gene in their body. And also in bilateral cases where they known to be germline, it's good to screen the family members, the parents and other siblings, because if they have the gene, to know their future about the offspring and to screen them for development of retinoblastoma. Now I will come to the retinoblastoma bizarre or abnormal or difficult presentations. So this is straightforward retinoblastoma, group C, with the exophytic type tumor, where is the retinal blood vessels dipping inside the tumor with subretinal seeds. This is straightforward, not difficult to diagnose. And this is group E, where the tumor is filling the whole posterior segment with the blood vessels dipping inside the tumor with no exudate. So this one also straightforward case, you cannot miss it. Now this one is straightforward Coats disease with crystalline deposit and xanthochoria, which is different from leukochoria. And also this is an easy case, straightforward, you cannot miss it. Now we come to this case. If I present it to a conference, an oncology meeting, 50-50. Somebody may say this could be Coats, this could be retinoblastoma. That's why we should do fluorescein angiography and other ancillary testing to confirm the diagnosis. So if you see with the fluorescein, the telangiectatic blood vessels, so this confirms the diagnosis, despite the picture being almost towards the retinoblastoma type. Also, the ultrasound could help you. Also, one of the things that you should know about the retinoblastoma, if you see a child that has never treated for any pathology in the eye with cataract, and you did a B scan and you found retinal detachment, and the B scan show query calcification, it's almost not retinoblastoma, because it's very rare in the literature to have retinoblastoma presented with cataract, only 1 or 2 reported cases. So if you have a cataract in a child and the B scan show you query retinoblastoma, it's unlikely, but it's not 100%. And also the presence of this crystalline deposit, the exudate, the subretina, is very important to differentiate the retinoblastoma from Coats disease in advanced cases, because the problem with retinoblastoma diagnosis and difficulty in large retinoblastoma tumor filling the whole posterior segment, like this case. So if you see a hard exudate, this is very unlikely, in a virgin eye not treated, this is very unlikely to be a retinoblastoma. See, retinoblastoma almost never develop exudate except after treatment. This is one of my patients. He developed exudate after receiving cycles of chemotherapy and regressing of the tumor. If you see an exudate in a virgin eye never treated, this is unlikely to be retinoblastoma. Also, this case received as a case of retinoblastoma with retrolental membrane and the B scan showing calcification. So calcification is not pathognomonic for retinoblastoma. Many pathologies in the retina and posterior segment, with time, the RBE and the retina can form osseous metaplasia with calcification. Phthisis bulbi. In advanced cases, if you do B scan, you will find calcification. So this is not a retinoblastoma. Like this one, persistent fetal vasculature, advanced case with retrolental membrane. If you do B scan, you will find a calcification. So this is not retinoblastoma. You should do proper examination of the periphery of dilated pupil, and if you concentrate here, you find the elongated ciliary process, even in the presence of calcification. This is not a retinoblastoma. Sometimes we face a case in the ER with orbital cellulitis and treated as orbital cellulitis. If you don't examine the eye properly and you take proper exam, you can miss it. This patient presents with advanced retinoblastoma and orbital extension of the tumor, and he was diagnosed as orbital cellulitis. Also, the last not the least, the vitreous seeds of retinoblastoma. It's not difficult to diagnose vitreous seeds of retinoblastoma if you could see the tumor in front of you. But sometimes, like this, sorry, the pointer is not clear on the project. So, but sometimes, like on the right side, you could see the tumor with the vitreous seeds. So you cannot make a mistake with diagnosing vitreous seeds of retinoblastoma. While this one is endophthalmitis, clear picture of endophthalmitis, post cataract with hypopyon and the fibrin reaction. But sometimes you face a picture like this in a child with query history of trauma by the parents, or he was in ICU, like this patient, he was in ICU for 1 month because of sepsis, and he was diagnosed as endogenous endophthalmitis by mistake. And this is, you cannot see a tumor by fundus exam because of the vitreous seeds. And this is very dangerous. If you label him as endogenous endophthalmitis and you tab him, and during the tab there is regurgitation of vitreous seeds under the conjunctiva, so you convert this child from a retinoblastoma inside eye to 100% mortality rate. So retinoblastoma outside the eye, almost 100% the mortality rate. That's why I am teaching the resident and the fellows about the retinoblastoma. If you have a doubt about a child with vitreous seeds or vitreous opacity and the history is not clear, never tab him. And never think about endophthalmitis until you are 100% sure this is not a retinoblastoma, because you are not treating now the eye and blindness. You are converting a live child, and you are converting him from a live child to a dead child after a few months, because orbital retinoblastoma is fatal. Thank you very much.
I would like to thank the organizing committee to give me a chance to present this again, another serious condition we have to take care and manage properly and diagnose as early as possible. So we're going to talk about the intraocular lymphoma in general, and the most serious is the primary CNS lymphoma, or primary vitreoretinal lymphoma, we call it. So as you know, it's the primary vitreoretinal lymphoma or intraocular lymphoma. It usually almost always associated with primary CNS lymphoma, brain involvement. Many authors they join these two entities as under one entity. They call it nowadays is primary CNS lymphoma with ophthalmic variant, or just primary CNS lymphoma if only the brain involved without ocular involvement. Most of the primary CNS lymphoma is a B cell type, around 98%. Although we have 2% of T cell lymphoma, it's almost always bilateral in 80% of cases, although it's asymmetrical conditions. It had been described like in 1951, and a lot of names have been called these conditions as reticular cell sarcoma initially, then lymphosarcoma, then finally primary CNS lymphoma. As we said, the B cell type is the most common type of primary CNS lymphoma. Kaplan was the first one to describe the presence of B cells in the vitreous cavity. As we know, the vitreous cavity is devoid of the P cells, and the P cells in the vitreous cavity have been described by Kaplan's. It's considered as very rare conditions, but it's also, on the other hand, it's very serious conditions. Most commonly affected is elderly populations at the 6th to 7th decade. The general overall incidence is 0.5 per 100,000, while when we take the substitute of the groups, those ranging from 75 to 84-year-old, the incidence goes up to 2 in 100,000 per year. If you have a case of primary CNS lymphoma, I mean the brain involvement, you have a chance of 20% to have the primary vitreoretinal lymphoma, while the other way, when you have the intraocular involvement, you have like an 80 to 90%. Those patients, they might develop, either they have primary CNS lymphoma, the brain or spine involvement, or during the course of the disease, they might have develop the primary CNS lymphomas. It's almost always insidious onset. It's almost always mistaken as vitritis and uveitis. And most of the cases, they have been diagnosed 1 to 2 years later after the initiation or the start of the symptoms. Almost always they label them as vitritis. It's almost always they have been treated with topical or systemic corticosteroid or even local corticosteroids. These cases almost present as white and quiet eye, very little or none anterior segment inflammations, and most of the anterior segment cells that we see is reactive T cell rather than the malignant P cell. Posterior syndicate never happen in such conditions. The almost always they have the infiltrate in the subretinal space. They usually infiltrate the Brooks membrane and the retinal pigment epithelium. They might have also solid pigment epithelial detachments, and the cell, as we said, continue to proliferate between the Brooks membrane and the RPEs, and creates like retinal pigment epithelial and subretinal infiltrate. It looks like yellow and white infiltrate. We'll show a few pictures in a couple of seconds. Cystoid macular edema. When you have cystoid macular edema in vitritis cases, it's almost always uveitis rather than lymphoma. So lymphoma, extremely rarely to get cystoid macular edema. So this is the one patient around 70 years old, and he has, as you see, the white and quiet eye. When you concentrate over behind the eye wheel, you see this type of vitreous cells. So the lymphoma cells is quite larger than the vitreous cells, which is the reactive cells that we see in vitritis conditions. And they usually have like a sheet of the cells or cluster of cells. If you see this another condition, you can see the right eye is, how is the media is not clear in the right eye compared to the left eye. The vitritis here is because of, or the vitreous opacity because of the lymphoma. And these conditions usually they have very good visual acuity. Although you have this significant vitritis, but they usually have a good visual acuity ranging from 20/25 to 20/30, sometimes 20/40 even. So this is another conditions. You can see these clusters of vitreal membranes, and you see this extensive subretinal infiltrate. And you can see on the right side is a magnification of the subretinal infiltrate. You can see here to differentiate these from retinoblastoma and the other conditions, you can see it is subretinal. You can see the blood vessel cross over the lesions. And this is another conditions, and this case has been treated as initially as acute retinal necrosis. And it's almost typical, it looks like acute retinal necrosis. But when you look deep, it looks a bit deep. It's not in the retina, it's just under the retina. MRI is very critical in these conditions. As we said, around 90% of cases they have CNS involvement or brain involvement, and sometimes you need to do the MRI for the spine also and the lumbar puncture to check for the CSF for malignant cells. So to diagnose primary vitreoretinal lymphoma or intraocular lymphoma, you have to have a definitive diagnosis for identifying the malignant cells. As it's a general rule in any cancer tumors, you have to have a tissue specimen to identify the malignant cells. Suggestive history of elderly patients with an infectious uveitis who is responding poorly to immunosuppressant agents or even not responding to immunosuppressant agents. Also, this raises suspicious of of primary vitreoretinal lymphomas. As we said, the visual acuity usually better than the clinical picture during good examinations. The imaging modality that might help us in the diagnosis, including fundus autofluorescence, fluorescein angiography, and OCT, although they are not pathognomonic for identifying or diagnosing the lymphoma. As we said, we have to have identifying the malignant cells in the vitreous cavity. The MRI of the brain is very critical in these conditions. If you see an elderly patient at the age of 65, 78 years with vitritis, do MRI, rule out primary CNS lymphomas. The sample can be taken from aqueous. As we said, the aqueous is not very sensitive because, as we said, most of the cells that we see in the anterior chamber, it's reactive T cells, not the malignant cells. That's why the aqueous sample is not really helpful. The diagnostic vitrectomy is very important. So the diagnostic vitrectomy, the sensitivity reach up to 67%. Some reports it reach up to 83%. Sometimes we don't reach the diagnosis even with the vitrectomy, so we have to have diluted and undiluted sample from the vitreous cavity. I will leave that for Dr. Abdullah Kahtani, who will present the diagnostic modalities. Sometimes we go deeper and we get the retinocoroidal biopsy. In elderly era, in the old era, they were doing just inoculations because they don't know the diagnosis and to reach the diagnosis. Nowadays, we don't do inoculation anymore for these conditions. This is the histopathology is very important. Cytology, you have to have a good cytologist to read the lymphoma. So the lymphoma is one of the most difficult condition to diagnose. Even if you get the sample, even if you get the biopsy, you have to have a good cytologist to read your specimen. This is just a histopath showing the large malignant lymphocyte. This specimen actually from the brain, it's not from the eye. The other diagnostic modality is immunohistochemistry. This is the second line. So we have the cytology and we have immunohistochemistry. This is the most two important diagnostic tools to reach the diagnosis. So to observe the monoclonality and to identify the markers on the B cells, looking for the CD20 cells. Sometimes you get when you get the sample, they get a lot of CD3 T cells. CD3 T cells is, as we said, it's a reactive T cell. Sometimes is by cytologists misread as an inflammatory condition or process rather than lymphomas. Tumor marker, another modalities that have been used to diagnose interleukin-2. We know in uveitis in general, interleukin-6 goes up, while in the lymphoma, the interleukin-10 it goes up and increases. So the interleukin-10, interleukin-6 ratio is very important. If it's more than 1, this goes with the lymphoma. Again, it's not diagnosed. They actually use this interleukin level or tumor marker. It's not for diagnosis, mainly it's for the response to the chemotherapy that we give to our patients. Molecular analysis, polymerase chain reaction, another modalities of diagnosis. As we said, the two important diagnostic tool is to have specimen to identify the malignant cell by histology and cytology, and immunohistochemistry to identify the CD20 and the monoclonality. Treatment depends on the involvement. So if the only eye involved, it depends unilateral or bilateral. So as we said, it's almost always bilateral, although it's symmetrical. If it's only one eye involved, you can treat with the local treatment, either external beam radiations or intravitreal chemotherapy. If it is bilateral disease and the brain is not involved and the spine is not involved, again you can treat with the external beam radiations, plus minus systemic chemotherapy. Some authors suggest systemic chemotherapy to reduce the risk of the brain involvement, although it's not an evidence-based. Of course, if you have systemic disease, if you have the brain involved, if you have the spine involved, no questions, you have to start the systemic chemotherapy plus minus external PMR radiations. External PMR radiation is as we said, preferable in bilateral disease without systemic involvement. The dose usually in the 40 gray, delivered over 15 interrupted fractions. So again, you have to have a good collaborations with the ocular oncologist, with the neuro-oncologist to treat those patients. Try to avoid external PMR radiation in those patients beyond 65 or 70 years old, because they find it one of the main complications is neurotoxicity. So they get the cognitive behavior changes and personality changes after the external PMR radiations. The second modality is the intravitreal chemotherapy. We have two modalities, intravitreal methotrexate and intravitreal rituximab. Most of the authors using intravitreal methotrexate, and the protocol that have been used nowadays is agreed upon is to give like 25 injection for the first year. So 25 injection, we call it induction, consolidation, and maintenance dose. The first month you give twice a dose every week. So 2 injection every week for the first month, the second 2 months every week, and the rest of the year on monthly basis. Most of those patients, they show a response around like 12 or 13 injections. And the dose, as we said, 400 microgram per 0.1 ml. We know that methotrexate is very toxic to the epithelium, for the conjunctiva, the cornea, and it might cause cataract. So you have to, in the technique, you have to press after you inject. Try to avoid egress of this medication over the conjunctiva and the cornea. The second modality, intravitreal rituximab, it's a humanized monoclonal antibody against CD20 cells, and it shows an efficacy, and its efficacy ranging from 3 to 4 weeks. So we give injection every 4 weeks. The median prognosis, the progression-free survival or overall survival ranging from 18 to 31 months. So as we said, we give a history of this subsequent CNS involvement. MRI is very critical in this condition, even if the initial MRI is negative. So every now and then you have to repeat the MRI to rule out the CNS involvement. The second disease, it's mainly indolent disease with newly discovered primary uveal lymphomas. So they present as birdshot keratoenopathy. They usually present with the choroidal lesions. It's not as aggressive as primary CNS lymphoma, and again, it's mostly secondary to the B cell, but with very low grade malignancy. It behaves like orbital and conjunctival melanoma, which is extranodal marginal zone lymphomas. It can involve choroid, it can involve iris or ciliary body. Predominantly unilateral compared to the primary CNS lymphomas. Men mainly affected, and the age usually younger than the primary CNS lymphoma, around the 5th decade.
Dr. Yahya, you have almost 1 minute left.
Okay, so this is how they present actually. If you look at these pictures, you say this is birdshot keratoenopathy. Ultrasound is very important. When you look at ultrasound, it's very thick choroid, and you see the extrascleral extensions of the lymphoma cells. And this is the conch, how it looks like a salmon patch. So the diagnosis here is, if you have like access to the conjunctival lesions, this is the easiest way to do. The treatment is the definite treatment is external PMR radiation. They are very sensitive to external PMR radiations. If you have systemic involvement and you need to check for the systemic, doing CT chest for the abdomen and pelvis, rule out the retroperitoneal lymph nodes, then systemic chemotherapy should be used in this condition. Thank you very much.
Dear Chairman, audience, it's a pleasure to share with you this talk, and it's going to be about the ocular lymphoma. So in some way of classification, they divide it to 3 types, which is the choroidal, either by metastasis, marginal zones, some people call it marginal zone, which is involving the conjunctiva and all the soft tissue, and vitreoretinal lymphoma as final nomination of this type of disease. So actually, there is a typical way of presenting the lymphoma and atypical way. Typical way, usually you have non-granulomatous vitreoretinal infiltration, non-clustering, even though it can exist in some part more than other part, And this is where you should guide the tip of the vitrectomy to get the highest chance for diagnosis. But the main changes that you will see it in the fundus in lymphoma is retinal pigment changes. It's almost like 65 to 70% of the patient, you will see some retinal pigment changes. And this is actually go more with the chronicity of this type of disease. As you see, also this is a choroidal example, and it's go all after the treatment, as you see it in the lower slide. This is the lymphoma of the marginal zone, which is usually a low-grade malignancy, and it show conjunctival infiltration, or even can be manifested as anterior and posterior scleritis. This is one of the atypical way of presenting the lymphoma, in which you will get a nerve infiltration. It's very rare to get nerve infiltration by a lymphoma. Subretinal infiltration also is there. Cns infiltration, as discussed by Dr. Yahya. And this sometimes it can present it also as an exudative retinal attachment, in which after treatment all this exudation can go and you can get a retina flat with a clear vitreous cavity. Cytology, of course, is very important, and you will see the undifferentiated lymphocyte. This is also an example of atypical presentation of the disease. So most of the time you will get the precipitation, corneal precipitation. If it's happened, it should be non-granulomatous as a characteristic. But it doesn't mean that you may not get a granulomatous precipitation on the cornea. So just to keep it in your mind, that there is 20%, we can call them atypical presentation of lymphoma. And usually when you get the atypical form, it's very difficult to treat it. It's actually it's category of the group that it will be resistant, it will be relapsing from time and other. So this is the precipitate even on lens. Subretinal infiltration, and very rarely you may get like a tuberculous presentation or vasculitis-like presentation, which is very rare, but it can happen and it's published. As we said, the retinal pigment changes is one of the most common presentation. This is the example of the CNS infiltration, and as you know, it's almost like 60% of the patient will present it as eye first, then 20% will be metastasized to the brain. And there is 20% who start in the brain and can go to the eye. So whenever you get an eye manifestation, think of brain. And whenever you get a brain manifestation, think of eye. As you know, a highway is the optic nerve there, so you can get a metastasis through this optic nerve. So this is what we talk about it. Most of the time, lymphoma will be presented like uveitis. So how to differentiate between uveitis and primary intraocular lymphoma, or what we call it now vitreoretinal lymphoma. This is the old name. So usually the lymphoma is older, and usually the AC is infiltrated, but non-granulomatous. And it's very rare that you get a vasculitis. It's very rare that you get synechiae. This is one of our articles get published about the Miscarriage Syndrome, a typical presentation of primary intraocular lymphoma, in which we present 4 cases. Some like tuberculous manifestation, other is like autoimmune, and other non-common manifestation. It was published in 2014, and there is a lot of talk about IL-10 has been discussed by Dr. Yahya and its modality of application. It's true, as he said, it's not very precise to pick the diagnosis, but it still could be applied as a screening tool, non-objective at the same time. I just show this slide. It's one of our study that we did it in Paris. It show actually how much the IL-10 can go down after the treatment by methotrexate injection. And at that time, we were seeing which one can decrease the IL-10 more. Is it the systemic one or the intravitreal methotrexate? And actually, we found that both is valid for treatment, but we noticed that the IL-10 go faster when you treat systemically. And actually, we find it associated with less relapse than if you treat it intravitreally. So we designed a study on that, and we are going to publish it soon. So the aim of the study is to see whether the IL-10 can be used as a screening test or no. We have 14 cases, and all go of what we said before is that after the intravitreal methotrexate injection, all the IL-10 measurement has been decreased from the anterior chamber. So the red bar is the IL-10 measurement before the treatment, and the blue one is the one after the treatment. If you see the eye number 7, it was not responding to the same amount of treatment that we give it to the other. And those actually is the one that we face a relapse later on soonly. So when you get a patient who is responding but not as fast as you expect, that means you should watch this patient carefully. This patient may relapse later on. This is just a comparing between the systemic treatment and a local treatment. Of course, this is just a small number of cases. As you know, those cases is not very common. Although it's not very rare, but just to show you how much the systemic can decrease the IL-10 faster. Being objective is one of the main goal that we are going to develop it. And we go now to what is the best way to diagnose lymphoma is by vitrectomy. And actually, vitrectomy has to be now applied in many fields because it's become safer and faster with highest cut, whatever, and easier because it's become smaller. You didn't need to suture it. It's self-sealing, and it can be applied in CRVO, PRVO, and diabetic macular edema, and now on Ocular Oncology. Diagnostic vitrectomy, it's a vitrectomy like any other type of vitrectomy. You just keep the infusion closed. Your goal is to get 1 ml of pure vitreous that should be obtained by the syringe attached to vitrectomy, and you have to be careful that in some type of machine, the connection in which you connect your syringe is far away from the tip. So you can get it like 80 centimeter away from the tip. So that means you have to have a big syringe just to withdraw all those amount through all this long tube till you get it inside the syringe and send it for cytopath. Specimen has to be sent immediately, actually. And the laboratory has to be aware that he has to wait the specimen to analyze it immediately. And cytology, as you know, is the main way of diagnosing. And usually the case or the specimen has to be centrifuged 600 times for 8 minutes. And this is to get 1 or 2 vitreous slides. The diluted, you can send it for culture. Cytokine has to be undiluted, because if you dilute it, sometimes you will get a false low reading. At the beginning, people was looking for IL-10. Then with time, they start developing IL-6 and making the ratio between them. Either each way can work nicely. Clonality is also very important to see what type of cell that you have. And we have advice for the type of vitrectomy that you are using. In the past, 20 was more preferred for oncology more than the smaller gauge, because if somebody has tried a fine needle aspiration, it's usually you get nothing with fine needle aspiration. With vitrectomy, sometimes you may get a false negative reading by laboratory. So how it's gonna get something by fine needle aspiration? Some people develop a technique. They said, no, we don't want to do vitrectomy, we will do fine needle aspiration. So what they do actually, they go in and out, 2-3 times, just to detach some amount of cells and withdraw it and send it for laboratory if he can find those small cells. So vitrectomy is become really now the main way to apply the biopsy, and we prefer 5 ml syringe as a rule for all of those gauge that you are using. Except that the 10 ml syringe, we prefer it for the long tube connection in some vitrectomy. Okay, so this is actually is a video how your assistant is gonna withdraw the biopsy or the specimen, and usually your goal is to get 1 ml pure at the time you are closing the infusion. If you are afraid from collapsing of the eye, you can open the air, but make sure that there is no remnant of the fluid inside the tube before you are opening the air. And usually at the end, you should get this specimen. This is not a lymphoma, by the way. This is tuberculous uveitis, but just to show you how we do the technique, because it's black actually. So we have talked a lot about the technique in this article, and we develop our own pedagogy or paragraph just to reach the diagnosis. So whenever you have a vitreoretinal suspicion of lymphoma, you do a brain MRI. As we said, the engagement of central nervous system and the eye is very common. So MRI is safe. You can do it for everybody that you suspect. If it was positive, you will consult the neuro and oncologist, and you can start either systemic or intrathecal. If it was negative, I mean the MRI, there is no localized lesion, you can think of CSF specimen. And why we said which is more safer, CSF or vitrectomy? Actually, CSF is more safer and easier to do it. So this is why we prefer to start with CSF. If you find it negative, then at this time you think of diagnosing vitrectomy. If the diagnostic vitrectomy become negative, then you have to revise your differential diagnosis. This technique has 80% success rate, let's say, because even though with the negative result, which could be false negative result, you can have the diagnosis.
Interesting, but I have to tell you it's 1 minute.
Sure, 1 minute I will be done. This is one of my patients, conjunctival redness, has been treated with steroid, and for 6 months no improvement. We think it's a lymphoma. We take biopsy, we send it to the lab, result was negative. Patient go and come many times. I refuse to do second. I talk with the oncology. I told him this is for me is a lymphoma. I don't need to see the patient anymore again unless you accept this is lymphoma. And sometimes you cannot be sure of what you are saying. And sometimes you can do a mistake by proposing the treatment for the patient. I give the patient the idea that we stuck with him. We don't know what is it. Then my feeling, this is lymphoma. And he said, I feel tired also at the same time. And we discuss with the oncology. Oncology take the decision to treat him by chemotherapy because lymphoma have a good responding to chemotherapy. Then, fortunately, and I'm really saying fortunately because treating chemotherapy for a patient, and you don't have a diagnostic vitrectomy, you shouldn't be proud of it. It's a very mistaken decision. But fortunately, the patient is okay and he get treated 3 years now. He's doing fine and he's still contacting me and thanks me, and this is photo sent by him for showing these cases. Being objective is very important. Thank you very much.
Good morning, everyone. I would like to thank the organizing committee for their very kind invitation. A special thank to Dr. Abdullah Qahtani. Thank you very much. My talk this morning is Hypersonic Vitrectomy, Promising Surgical Technology. Let's see some background about this. In fact, Dr. Kellman was the first who applied the technology using both irrigation over a tubular tip and aspiration applied to the bore of the tube. His method was successfully applied to extraction of cataracts and now universally used for this purpose in a surgical procedure known as phacoemulsification. In 1979, Lichteb published a report of vitreous liquefaction by the use of 60 kilohertz. Their result were liquefied vitreous with viscosity almost the same as water, whereas the vitreous optical transparency remains unchanged. The study did not examine the effect on other ocular tissue. In fact, what matters about mechanical vitrectomy is the gauge size, cuts per minute, and fluidics. This is the evolution, smaller and smaller in mechanical vitrectomy. You can see Dr. Macular in 1972, it was 16 gauge, and now there are 20, 23, 25, and 27 gauge. This is physics as well. At cut rate of 5,000 cuts per minute results in a smaller particles that creates a lower viscosity fluid resulting in a higher flow. And that leads to minimized retinal traction, while lower cut rate results in larger particles, which increases vitreous traction and decreased flow, and this increases the risk of retinal damage. Talking about fluidics, a flow through a vitreous cutter is affected by pressure difference, cutter and tubing dimensions, properties of the aspirated material, and duty cycle. That's why researchers came out with a twin duty cycle cutter, TDC by Dork this time here, and the effort to improve flow control have focused on keeping the port open at the maximum to allow as much time while keeping the cut rate very high. In case of Dork, it's 8,000 by 2, it becomes 16,000 cuts per minute. Once again, what are the limitations of mechanical vitrectomy? Once again, gauge size, cuts per minute, and fluidics. But all of this are running into mechanical limitations, so this is when technology needs to be evolved. Hypersonic vitrectomy, what it is? It uses a single needle design with a small continuously open port, as you can see, one single use handpiece vibrating harmonically equivalent of 1.7 million cycles per minute. It's 1.7 cuts per minute, million per minute. A new Stellaris PC accessory device for posterior vitrectomy uses a novel closed single needle design with a small continuously open port in a single use handpiece vibrating in a harmonic way. It is a unit that is built into the Stellaris machine. The handpiece technology needle is mounted. Piezoelectric transducer element vibrating harmonically yields virtual cut rate of approximately 1.7 million cuts per minute. You can see it very clearly there. You can see that in hypersonic vitrectomy, the vitreous gets emulsified at the tip, at the opening, outside the port, not inside the port like mechanical vitrectomy. And this is an example. This is 5,000 cuts per minute where vitreous get chewed. It gets sucked and cut and emulsified inside the port. While in hypersonic vitrectomy, the vitreous is emulsified outside the tip. That's why the opening is so small. And vitreous, there is no traction absolutely any traction, because the vitreous gets emulsified at the tip of the cutter or at the probe. The goal of this is vitrectomy with no traction and turbulence. In fact, the high rate directly addresses the clinical need to minimize turbulence and reduce tractional forces during surgery. Turbulence is associated with adverse events such as induced retinal detachment. As the cut rate increases, turbulence has been shown to decrease along with traction on the retina. At the cut rates inherent in hypersonic liquefaction, it has been shown that cutting action is so rapid that tissue do not have time to react and appear to remain stable, stationary, while tissue in the immediate proximity is excised. Other potential applications for this technology right now is fluoterectomy, posterior vitreous detachment, and silicone oil removal and lens removal. The advantages over guillotine cutters: much higher virtual cutting rate, 1.7, comparing at the maximum 16,000 cuts per minute. The port is always open, all way the procedure, and you can place the opening of the tip anywhere you like. And you can even have more one opening on the tip. Single use, single needle instead of two needles, therefore the inner lumen of diameter can be larger, thus providing lower flow resistance and facilitating the use of smaller gauges. In fact, what is available now is 23 gauge, but this can be developed in 27, 28, even 30 gauge, because there is nothing inside. It's an empty needle. Those are some of the advantages of this technology over mechanical vitrectomy. You can see there are no traction, no disruption, no resistance, potentially closer. You can go so close to the retina, but you have to adjust the ultrasonic power, less time, distance between breaks. One of our main research centers in this study is in Manchester by Dr. Stanga, and he did many studies over there, and he studies the flow rate with this technology, and it was much better than the mechanical weight. Studying the microscopy of the retinal tissue, there was no damage whatsoever, and it was comparable with the mechanical vitrectomy, the histology of the retina in human cadaveric eyes and in animal eyes. In fact, in 2013, the viscosity, and there was a paper showing the viscosity and elasticity chopped vitreous substantially change from those of intact vitreous. Viscosity decrease, elasticity increase. Cut rate affects the rheological properties, the chopped vitreous, and therefore its flow inside the vitrectomy system. This is comparing mechanical vitrectomy, the histopathology of the vitreous, with ultrasonic vitrectomy. It is much more liquefied in case of hypersonic vitrectomy. And as I mentioned before, in case of hypersonic vitrectomy, the liquefaction comes outside the port and not inside the port. That's why there is no traction, zero traction. This is small video by Dr. Owa showing removing the vitreous just core vitrectomy. It was so simple, just the vitreous come inside the port with zero traction. Finally, we have encouraging preliminary results, active research and development in progress. Right now, we apply to the FDA in the US and waiting for their approval. There will be multi-center studies across the world And we will have one in the Middle East. It will be at the Jordan Hospital where I am practicing. And we are waiting for FDA approval so we can start our multi-center studies. And thank you very much.
I would like to thank the organization committee to give me for giving me this opportunity to talk to you about small gauge endoscopy, guided peeling of anterior PVR. None of the authors have any financial interest to disclose. So I'll identify the risk factors for PVR, recognize the serious consequences of PVR. I'll explain briefly the different surgical techniques for PVR management, and then I'll explain to you the surgical advantages of small gauge endoscopy in anterior PVR treatment, and hopefully by the end we'll recognize the potential benefits of small gauge endoscopy in cases of anterior PVR. So proliferative vitreoretinopathy, it's a syndrome of proliferation of cells on the inner and outer surfaces of the retina and the vitreous leading to retinal traction and detachment. It is the most common cause of failure of retinal detachment surgery. It has an incidence of about 5 to 10% of all rheumatogenic detachments. It has several risk factors, the most common being previous retinal detachment repair, penetrating trauma, giant retinal tears or large breaks, vitreous hemorrhage with tears, previous PVR, retinal detachment involving more than 2 quadrants, retinal detachment with choroidal detachment, heavy cryotherapy, subretinal vitreous bleeding, and other several factors. So briefly, the pathogenesis, it occurs within 4 to 12 weeks post-op. And there is the 2 cornerstones of PVR formation is intravitreal dispersion of RPE and breakdown of the blood-retinal barrier. The membranes are composed of glial cells, retinal pigment epithelium, immune cells including macrophages and neutrophils, fibrocytes and myofibrocytes. There's thrombin and fibronectin acting along with multiple growth factors, chemotactic factors, and cytokines, and this is beyond the scope of this presentation. So why do we fear PVR? It is the most common cause of recurrent retinal detachment, and PVR involving the macula will lead to permanent visual loss despite anything that we do. In a lot of cases, there is shortening of the retina necessitating retinectomy, and this has another series of possible complications afterwards. In cases of retinal detachment with PVR treated with retinotomy or retinectomy, they found that the risk of low IOP falls between 11 to 39%. In cases with equatorial PVR, contraction of PVR may lead to funnel-shaped RD, and this is one of our nightmares in surgery. So one more thing is that ciliary body fibrosis due to PVR carries a high risk of atrophy of the ciliary processes, ciliary body detachment, chronic hypotony, and eventually phthisis bulbi. The 2 main surgical techniques that people prefer are either scleral buckling with vitrectomy or vitrectomy alone. And there are studies that showed the benefit of one over the other or the equality between them. So essentially, whether you do vitrectomy with buckle or vitrectomy alone, you have to relieve all traction by division and peeling or by delamination of the membranes. Meticulous vitreous base shaving is essential with removal of subretinal membranes if they prevent retinal flattening at the end of the case. Sometimes we revert to retinectomy and to relieve the shortening, to cut the shortened retina. Bleeding control is essential as bleeding intraoperatively or at the margin of the retinectomy may induce recurrence of PVR. To flatten the retina, some people prefer using PFO, perfluorooctane, perfluorocarbon, or sometimes fluid air exchange. The bottom line is that the retina has to flatten by either of these methods. And if it doesn't flatten, it means there is still PVR inducing traction and it has to be relieved, otherwise the surgery will fail. At the end, it's preferable to use laser retinopexy over cryo, as cryo may induce more PVR, but if you don't have an option, you have to use cryo. So some groups looked at compared vitrectomy versus scleral buckling with vitrectomy. So this group of Will's PVR study group was published in 2014. They had patients with high risk of PVR. These patients did not have PVR, but they were labeled as high risk for PVR. They had over 600 patients, and they found that vitrectomy with buckling had a superior outcome to vitrectomy alone. Another group published in BMC Ophthalmology 2015, they found that patients who had PVR they compared patients who had previous buckling surgery versus vitrectomy. So patients who had PVR with buckling surgery and underwent vitrectomy with retinectomy, they had a better outcome than patients who only had vitrectomy. So essentially, patients that had buckle with vitrectomy did better than vitrectomy alone. On the other hand, a group published last April 2016, they showed that combined buckling with vitrectomy versus vitrectomy alone were comparable. There was no significant difference between them. So, to switch to the anterior proliferative vitreoretinopathy, which is a challenging case to all retinal surgeons. The surgical difficulty comes in the fact that when we operate, we look through the pupil. So whatever is underneath the pupil or at the very anterior part of the pars plana, it's an area of difficult access, and this comes by the nature of the way we operate. And detection of early anterior PVR is difficult using the conventional way through the pupil, as I mentioned. So there are several groups that looked at the benefit of endoscopy in endoscopic surgery in PVR, anterior PVR. For the sake of time, I'm not going to go through a lot of studies, but this is one that was published in 2016 by Gregory and his team. They found that endoscopic assisted vitrectomy salvaged eyes from low IOP, but they found this in a minority of cases. Now, the study did not mention what is the proper timing to operate, who are the patients that would benefit the most. It's raised a lot of questions and important questions, but it did show benefit of this technique. Now, in the study I will talk about, we showed some more detailed results, but I will show you briefly how endoscopic surgery looks at the beginning. So this is a video you can appreciate there. So just to pause it for a second, these cases are either done by myself or by mentor Flavio Resende in my fellowship. And in cases of retinal detachment, we shave the vitreous meticulously at the base. Like, we do all measures to shave all the vitreous. But once we did the endoscopic surgery, we found that there's a lot of vitreous remaining right behind the iris and the anterior part of the pars plana, which wasn't accessible before. So I'll show you the video here. There's no significant PVR in this case, but you can see the remaining vitreous with the pigment clumps. These are the ciliary body processes. This is the posterior surface of the iris. There were some membranes that were peeled. For the sake of time, I'm going to advance through it. I'm just giving you an idea of how it looks. And this shows the difficulty of the surgery because it's a two-dimensional surgery rather than three-dimensional surgery. So I'll show you two examples, and then I'll show you the series that we have. First case, 58-year-old man presented with right eye MAC-on detachment due to giant retinal tear, high risk for PVR. Vision was 20/20, IOP was 14. He underwent the conventional surgery, 25 gauge PVR grade B peeling with C3F8. After 3 months, he developed a recurrent RD, and the cause of recurrent RD was labeled as PVR grade B. IOP at the time, IOP at the time was 0. Clinically, there was no ciliary body fibrosis identified. He was delayed only 4 days from presentation to surgery, and he underwent phacoemulsification with IOL implantation, 25 gauge vitrectomy, small gauge endoscopy guided surgery, PVR peeling, 360 degrees retinectomy. ciliary body fibrosis peeling, and silicone oil. This is an example of how the normal ciliary body and the anterior pars plana looks like. You can see how the ciliary processes are all well defined. This is the cannula there. This is the posterior iris surface. This is one of our patients in the series. And this is our patient that I'm presenting to you. Areas of anterior fibrosis. The ciliary processes are there. It's covered by fibrosis, but it's not atrophied. And that's very important. We went through the endoscopic surgery. We peeled with a forceps in this image. And then you have the membranes there, peeling with a 25 gauge vitrector. And this is after peeling. This is how it looked. The ciliary processes were in a good health. There was no more tractional membranes. This is the retinectomy edge with the laser and removing the subretinal fluid there. So 4 months post-op, patient had potential visual acuity of 20/25 under silicone oil. IOP was 7, from 0 went up to 7. Unfortunately, later on, he developed an area of posterior PVR with the localized retinal detachment, macula under the silicone oil. 11 months later, he comes to the clinic with unexplained visual loss, but the retina was in the same condition. We don't know, did he develop some hypoperfusion of the optic nerve? Was it toxicity from the silicone oil? We could not identify the cause. But what I could say is that IOP was 5, so it's not, a lot of studies look at IOP below 5 as hypotonia, so his IOP was 5, and his macula was still on. The second case is a sad case. He's a 66-year-old male. He's an engineer, came on with MAC-on RD, vitreous hemorrhage, counting fingers, IOP was 8, underwent a pneumatic retinopexy that failed. Then we did 23 gauge vitrectomy with gas. He had recurrent RD again. No clear fibrosis was identified. He underwent another surgery with PVR peeling and silicone oil. The RD recurred under silicone oil. And this was actually the case that initiated this whole study that we did, because we started using endoscopy. This was the first case. So he underwent another surgery using 25 gauge vitrectomy with the endoscope and peeling under endoscopy. So again, this is how the normal ciliary body processes look like. And this is to show you the difference between the conventional surgery, the non-contact wide-angle viewing system, versus the endoscopic surgery. So this is the same case I was discussing, the last case. Performing surgery there, entering, and this is, you can see here the retina is detached. We're depressing the sclera and peeling at the same time. Peeling is doable, but very difficult. We don't know what else is there. We're peeling just enormous membranes. We'll finish the surgery and close it. And then the second surgery that he did under endoscopy, you'll appreciate how different the view is. So we go from below, and then we're looking at the iris, and then we're seeing all these tractional membranes and fibrosis. The iris was fibrosed on the posterior surface. It was pretty ugly. And you can see how we rotate the endoscope. We're peeling with the membrane, or with the forceps. And these membranes, the longer that you leave the PVR membranes, the more tough it becomes. So these membranes were essentially like plastic. We couldn't even cut them with the vitrector at one point, so we had to try to just cut them in place. We couldn't remove them. We cut them in place and leave some parts of it. Removing it with the vitrector. It's a bimanual peeling under endoscope. I was holding the endoscope, and my mentor was actually doing bimanual peeling. This is how tough the case was. In any case, so this case is one of the sad ones, and the pressure remained low. His retina is attached under, his retina is attached under silicone oil, but he remained to have low IOP, and his eye became tisical with time. These are just illustrations from the same surgery. So IOP was 0, retina attached under silicone oil, and he has a tisical eye. So we did a retrospective review study to evaluate the advantages and limitations of small gauge endoscopy for the management of recurrent retinal detachment with anterior PVR. And we also intended to grade ciliary body fibrosis intraoperatively in an attempt to predict the contributing risk factors to chronic low IOP. At the time, we had 15 cases. Now we have a bigger number of cases with, hopefully we'll publish it soon. The number 2, 3, and 11 and 7 are the patient that I presented. I just want to show you patient number 11. So if you notice, there was traction, and then we did peeling, and the peeling was relatively
Dr.
easy,
Mohammed,
means that
you
the
have,
traction was not advanced.
30 seconds.
1 minute?
30 seconds.
30 seconds.
Thank you.
Okay. So in any case, the pressure in the earlier you peel and the less fibrosis, the better pressure, obviously. So we found that early detection and treatment of anterior PVR with ciliary body fibrosis reduced the risk of chronic hypotony, which is logical. Small gauge endoscopy is better than non-contact viewing system in diagnosing and management of anterior PVR. None of the patients who had retinectomy or retinotomy had IOP, had low IOP unrelated to fibrosis. So if the patient had fibrosis, there was low IOP. If there is no fibrosis, even with retinectomy, the pressure was still normal. So hopefully more studies will come look at this technique, and hopefully our paper will be published soon and with promising results. Thank you for your attention.